So really in this trial, we're looking at primarily treatments that are delivered directly into the bladder. We're trying to see firstly if one is better than another, and secondly, how do they compare with your standard treatment of daily antibiotics.
Professor Chris Harding is a consultant urological surgeon at Newcastle upon Tyne Hospital's NHS Foundation Trust and Professor of Urology at Newcastle University. He has a particular interest in bladder dysfunction, continence, neurourology, urinary tract infections, mesh complications, and clinical research. He is chair of the NIHR National Benign Urology Group and the current chair of the European Association of Urology Guidelines Panel for female non-neurogenic lower urinary tract symptoms, among many other things. Today, Professor Harding is here in his role as Chief Investigator for the VESPER clinical trial, which will compare 3 recurrent UTI prevention protocols. Thank you so much for joining me today to answer our community's questions about the trial.
Thank you for having me.
Let's jump straight into the questions. But before we discuss the clinical trial in more detail, can you provide some context for why this trial is being conducted?
So I think this trial hopefully will serve to provide an unmet need. And that unmet need is what you do with patients who fail first-line preventative treatments who have recurrent urinary tract infections, because currently there are no real evidence-based guidelines on the topic. So what we aim to provide in this trial is the evidence on which to base future guideline recommendations and perhaps even policy changes for what represents really a significant proportion of patients. So our previous work would suggest that between 10 and 20% of women will not respond to any of the first line treatments for recurrent urinary tract infection prevention. So really in this trial, we're looking at primarily treatments that are delivered directly into the bladder. So we call these intravesical treatments. And we're trying to see firstly if one is better than another, and secondly, how do they compare with your standard treatment of daily antibiotics.
Okay, sounds like a really important step for this community. What are the 3 treatment protocols that will be used in the trial?
So the first treatment protocol would be the standard NICE advised treatment, which would be a second line daily antibiotic. So for instance, if a patient has tried something like trimethoprim and that hasn't been beneficial, then we would try a second line antibiotic, which could be nitrofurantoin or daily cefalexin or daily amoxicillin, and they're the ones that NICE recommends. But as I say, this field is really a bit of an evidence-free area, particularly those with what I would call refractory recurrent UTIs.
How do you deliver medication directly into the bladder?
So medication that's given directly into the bladder is done via a catheter. So what we usually do, our usual practice, is to teach patients how to pass a catheter into their bladder. This is called self-catheterization, and then we provide them with the medication to give directly into the bladder. And I think the important thing then is that they try and retain that medication within the bladder for as long as they possibly can. So this is why home administration is really useful, because often patients can give it last thing before bed and hopefully leave it until they get up first thing in the morning, so it's had a significant dwell time. But you know, an overnight dwell time is not essential, but it's obviously preferable to get drug to the target site for as long as possible. But we would say that kind of minimum retention would be about an hour.
Okay, we do get a few questions about that because it can be difficult to hold something in your bladder, especially when
Exactly.
you have recurrent UTI symptoms. And what are the 2 treatments that will be instilled into the bladder?
So one is an antibiotic, and that's gentamicin, which most of your members will have heard of. It's a strong antibiotic, and the idea is that you're giving good concentration at the target site, which is within the bladder, and obviously that can have its direct antimicrobial effect. The other treatment is something we call gag replacement.
hmm
So the gag layer within the bladder is the innermost layer of the bladder. It's the first line of defense to stop bacteria from sticking to the bladder wall and then penetrating and colonizing the bladder wall. And the best example I can give is a bit like the kind of varnish which might protect wooden furniture. So it's that kind of outer coating that stops any damage to the underlying structure, in this case, the bladder wall. And this is generally the constituents of things like hyaluronic acid or chondroitin sulfate. These are just molecules that basically will protect the bladder wall from penetration by bacteria.
Is this gag layer treatment already used in the bladder?
So all of the treatments are in widespread use in
Hmm.
the UK. I mean, we did a survey before we dreamt up the trial to just see how much the treatments were used, and only 1 in 4 urology and urogynecology units that responded said they didn't use either of the two
Hmm.
treatments. So in essence, 3 out of every 4 urology or urogynecology units that we um, surveyed said that this was part of their standard pathway. But this is treatment that we're giving without good evidence. So this
Hmm.
is why we've got to provide that evidence, and it will either underline those treatments as a very good step in the clinical pathway or show that they don't have much effect, in which case, we can look for other things to help these women.
Right, also very important. And why was gentamicin chosen as the antibiotic for the intravesical treatment?
So gentamicin is the antibiotic with the biggest amount of evidence
Hmm.
behind it. So when I talk about a lack of evidence, what I'm really talking about is a kind of lack of randomized controlled trials. So, the highest level of clinical evidence. There's a lot of case series that have been produced. So an individual unit might report on a number of patients who've had that treatment and report their
Hmm.
outcomes. But the highest level of evidence is when you randomize patients to treatment. So there's no clinician or patient bias at all involved. This treatment is decided completely at random, and therefore you can compare the different groups in the trial and see which of the treatments comes out best.
Right, and if you deliver antibiotics straight into the bladder, is there still a risk of systemic side effects?
So no, the urothelial layer, which is the kind of one of the first cellular layers of the bladder, so just underneath that gag layer I was talking about,
Hmm.
that's relatively impenetrable because, of course, it's designed to deal with the waste products. So the last thing we want to do is reabsorb it into the bloodstream. Um, so theoretically, there's no absorption into the bloodstream of anything you instill into the bladder. But to confirm that, what we did is in Newcastle, we looked at a series of 30 patients who had intravesical gentamicin put into their bladder. And gentamicin is a chemical, an antibiotic that you can actually assay in the bloodstream. So we
Hmm.
did blood tests to check for any gentamicin levels in the bloodstream after we'd instilled the gentamicin and found none in any of the patients. So I think we can conclude that the theory is probably right, and
Hmm.
none of this antibiotic or indeed gag replacement substance would be absorbed. Now, that's especially important because one of the downsides of giving tablet antibiotics is they have to be absorbed in the system, and
Hmm.
particularly in the gut, before they have an effect. Now, what we don't want to do is deliver high concentrations of antibiotic into patients' gut, because that will undoubtedly accelerate resistance development and
Hmm.
also causes a lot of the side effects, the common side effects that you see with antibiotics, such as, these are gastrointestinal symptoms, such as antibiotic related diarrhea, abdominal pain, problems with digestion, things like that. So the idea is that these drugs go to the target site, stay there until they're eliminated when the patient voids.
Right, and how will you measure the success between the three protocols?
So we're looking at a clinical definition of urinary tract infection. So our previous work has showed us that the microbiological tests are not always reliable in terms of diagnosing a urinary tract infection.
Hmm.
So we are relying on a clinical definition, which is symptoms which are commensurate with urinary tract infection, and then the prescription of an antibiotic, which
Hmm.
confirms to us that a healthcare professional has deemed this as a likely urinary tract infection. And within the trial, the patients will, if they get a UTI, they will seek help in their usual way. So
Hmm.
they'll go to their GP, they'd go to a walk-in centre, they go to a pharmacy, and they would then be asked to record that antibiotic. So what antibiotic did they get and for how long? We will then check it with their primary care records and confirm that this was indeed an episode of urinary tract infection. So it doesn't rely on the microbiological tests that a lot
Mm-hmm.
of these patients have lost trust in.
Mm-hmm. Understandably. So that means if there is a participant in the trial who experiences a UTI and is treated for it, they can remain in the trial?
Oh, absolutely. I mean, patients will get UTIs
Mm-hmm.
within this trial. There's no treatment that I'm aware of that treats all patients
Yeah.
100%, and therefore this is why we're actually doing trials like this. And this is concentrating on really the more refractory cases. So it
Mm-hmm.
will be almost certainly, the patients will get a urinary tract infection. So, for instance, in the last trial that I did, the patients presented with an average of 7 UTIs per year.
Wow.
And we took that down to an average of about one with the trial
Mm-hmm.
treatments. Now, so that's not complete eradication of UTIs, but it takes it down to a manageable level. If it's down to one per year, you can kind of manage with that. But
Yeah.
you can imagine, can't you, that if a patient is getting a UTI every 7 or 8 weeks, that's going to have a massive impact on their quality of life. So it's these patients we want to help, but we don't
Mm-hmm.
make a promise to eradicate their UTIs, but we hope to reduce them significantly.
I think there's a lot of people in this community who would find that to be a very significant change.
Exactly.
It's probably a good time to talk about eligibility then. So who can participate in this trial?
So we are looking at female patients, so patients who were assigned female sex at birth,
Mm-hmm.
um, with what we call uncomplicated recurrent urinary tract infections. And that means there's not a correctable structural or functional abnormality. So examples would be if a patient had a significant level of kidney stones, or a patient was um, not emptying their bladder properly. These are structural and functional abnormalities that
Mm-hmm.
can feed into urinary tract, so they would be excluded. But the vast majority of patients with recurrent UTIs have a normal looking and a normal
Mm-hmm.
functioning urinary tract, but they just get colonized very, very readily with bacteria. And therefore, it's these patients we're looking at. So, really, I think it would probably mean that eligibility would be confirmed in about 90% of the patients that we see with recurrent UTI.
Okay.
So, it's going to be a trial that can be very generalizable in terms of the results.
And what age group are you looking at?
So, it's adult women. So, we just would exclude patients under 16 years of age.
Okay. And is this UK only?
It is UK only. We have a number of sites who have expressed an interest. We plan to roll the trial out to 20 sites,
Great.
and the 20 sites have not been fully decided yet. But we have decided the kind of first 4 or 5, and we will open these sites sequentially.
Mm-hmm.
But what we've been very mindful, there's two things that we've been very mindful to do when we're setting up the trial. The first one is to ensure that we've got good geographical coverage. So I want, most women in the UK who are eligible for this trial to have a fairly nearby trial centre that can administrate the treatments, that can monitor them throughout the trial, and so they would, you know, be able to participate. The other thing that we're really trying very hard to do is look at underrepresented groups in
Mm-hmm.
terms of maybe ethnicity, in terms of social class, things like that, because we want the trial results to be generalizable. So we want the trial population to be very representative of UK women who get recurrent UTIs. And unfortunately, we haven't always achieved that in the UTI trials. The vast majority of patients who go into UTI trials are of a certain demographic, and we're trying actively to try and change that, really.
Yeah, I think it's really important. Hopefully, people from our community will join the trial as well and help with those statistics. There's often a lot of questions that we get about participation. One of the main ones is, do you need to have symptoms of a UTI at the time that you join the trial, or is it something that would exclude you at that time?
It would exclude you at that point. So we want to take patients to start the trial when they're free of symptoms of a
Hmm.
UTI. So if a patient presents and they've got a UTI at the time, that wouldn't necessarily mean they couldn't participate. It just would mean that they couldn't participate at that moment. So what we would
Okay.
usually advise is they treat that UTI at the time with standard means, a course of antibiotics, and then we would reassess them after a couple of weeks. We would insist that the patient has been without antibiotic treatment for 4 weeks, because otherwise,
Okay.
if they've got any antibiotics in their system at trial entry, that could prejudice prejudiced the results. So it wouldn't rule them out, but we call it deferred trial entry. So we would just move the kind of timelines a little bit down the road a bit.
Okay. And how recently does someone need to have experienced their last UTI? If they don't have one right now, could they have had one 3 months ago and join the trial now?
Oh, absolutely, yeah. As long as they have a diagnosis of recurrent urinary tract infections that have not responded to first line treatments, then by definition they will still be getting 2 UTIs in a 6 month period or three in a year. So as long as that criterion is fulfilled, then they would be fine for trial entry on the basis that they had a normal structural and functional urinary tract. So most of these women will have had an ultrasound scan of their renal tract, which will confirm structural and functional normality. Some would have had a cystoscopy, which will again confirm structural normality of the bladder. So, these are the kind of tests that they would have had prior to coming into the trial.
Right.
And it's not necessarily what I don't want the trial to do is be the kind of stimulus for a load of different investigations, some of which they may have had already. So
Right.
we would just take that from previous records, really.
Okay, that's good to know. How many people are you looking for in total for the trial?
So we're looking at just over 400.
Mm-hmm.
So we're going to recruit for 20 months, hopefully starting towards the end of February of this year. And for the 20 months following that, we will be recruiting patients from all over the UK, which roughly equates to kind of recruiting, I don't know, about 18 to 20 per month. So, we do have to be fairly busy and ensure that we get a lot of interest in the trial. But I think it's something that we've looked at in kind of feasibility questionnaires for the individual sites, and we think it's achievable.
Okay, that's good to know. And you mentioned that you won't be doing any testing like cystoscopy or scans, but what will the screening process look like? Will there be blood tests involved or any other tests that people have to do?
Yeah, so there will be some things at baseline. So at baseline, the patients would have a medical record review. So we would confirm that they have recurrent uncomplicated urinary tract infections. We would confirm that they'd failed first line treatments, and we would look at previous investigations, but by no means do we want to repeat those. We
Right.
do, however, need some baseline results. So we would need a baseline blood test looking at sort of kidney and liver function, because one of the things we want to look at is, do these treatments on the trial affect kidney and liver function? We don't think they do, but that'll be really important to document. We'd also ask the patients to swab their perineal area, which is the area between the vagina and the anus, and that's to basically try and get an idea of what kind of bacteria are around that area,
Right.
because we're going to do that sequentially throughout the trial to see if any resistance develops on any of these treatments. So really, it's a window into the kind of bacteria that are in your colon.
Yeah.
And we've done that in previous UTI trials, and it's worked quite well. It's been a good window into possible resistance development. The other thing that the patients will do at baseline is they'll answer a lot of questionnaires. So one of which will be the Recurrent UTI Impact Questionnaire, which will basically give us an idea of how impactful this problem is in terms of their everyday life. And that'll be a really good baseline measure to then record any improvement going forward with the trial treatments.
Yeah, sounds really comprehensive. The next question we received is how will a participant be assigned to one of the treatment groups?
So completely at random. So in
Mm-hmm.
order for the trial results to be as powerful as they can be, it has to be completely at random. So one of the inclusion criteria is that the patient needs to be prepared to be randomized into either a second line tablet oral antibiotic or either of the two intravesical treatments that I've spoken about.
Mm-hmm.
And if there's any issues with any one of those trial arms, then it means they can't be randomized, so they probably couldn't enter the trial.
Okay. And how will the logistics happen with the administration of these treatments? How often will they have to have the medication instilled into the bladder or take the nitrofurantoin?
Yeah. Okay. So the daily tablets, which may be nitrofurantoin, but maybe trimethoprim, maybe
Mm-hmm.
cefalexin, maybe amoxicillin, they are taken daily for a 6 month period, which is pretty much what NICE advise, and
Mm-hmm.
NICE have recently updated their antimicrobial prescribing guidelines, and give the same kind of recommendations as they did in their 2018 guideline. Intravesical treatments will be given weekly for the first month, and then fortnightly for months 2 and 3, and then monthly for months 4, 5, and 6. So it's a total of 11 bladder installations, but we will be encouraging the patients to be self-instilling at home. So
Hmm.
that's why we will teach them how to catheterize
Okay.
themselves. We'll provide them with the trial treatments, and all we'll need is their confirmation that they've done it. And we found in our UTI clinic in Newcastle that well over 70, 80% can self-administer
Hmm.
treatment. If the patients can't self-administer, then they would obviously have to attend the hospital for these installations, which would be in the kind of in the schedule that I've outlined already.
If they do have to travel to the site, will their travel be reimbursed?
So anything over and above standard clinical care is reimbursed.
Hmm.
So we calculate that 2 visits would
Hmm.
be reimbursed because that would be over and above what we would usually do.
Okay.
But attendance for weekly installations or fortnightly or monthly, depending on how far on they are in the trial, they wouldn't be reimbursed because that's standard care.
Right. But they also don't then have to pay anything for the appointments or for the treatment.
No, no, no. This is all done under the NHS, so there's no sort of fees for appointments or treatments or anything like that.
Okay, great. And so how can someone join the trial? Can they join it directly or do they need to get a referral from another clinician?
So they would need to be referred into one of the trial centres, either via their GP or another clinician that they're seeing, with the specific information on the referral that they want to be considered
Hmm.
for the trial. Because, of course, if a standard referral comes in and they just see recurrent urinary tract infections, then the waiting times for these appointments are colossal, and the trial will probably be finished by the time they
Right.
get an appointment. So we need
Hmm.
specific information, but we've got a kind of a GP information sheet that we are roughly about finalized, and that can be accessed pretty easily on the trial website, and then obviously the GP can fill it in and send it to the trial center. We'll have
Hmm.
a designated principal investigator in every center, so that's where the referrals will go, and they will hopefully then be able to pick them up and get the patients enrolled in the trial.
Okay,
So it
great.
should be smooth. So the idea, just to recap, is that there's going to be a trial centre somewhere near most patients in the UK. There'll
Hmm.
be a designated person who will administer the trial within that centre, and that's where the referrals will be directed to.
Okay, we'll make sure we put the link for the study website in the video
Yes.
description so people can find it directly. There was another question about participation in the trial. Can participants use vaginal estrogen, Hiprex, or other over-the-counter supplements while they're in the trial?
So Hiprex is not an over-the-counter supplement in the UK, so
Yeah.
we wouldn't advocate using that. Vaginal
Hmm.
estrogen, yes, I wouldn't object to that. We would
Okay.
obviously be recording that in terms of the trial documentation. Other things that they might be using, cranberry,
Hmm.
D-mannose, that they would be permitted as well, but not a prescription medication because, of course, with the recent change in the NICE guidelines, Hiprex is now, or methenamine hippurate, as it's correctly termed,
Hmm.
that's now recommended as a first-line treatment. So if patients have failed that, they would then be eligible for entry into the trial, but they shouldn't continue taking it within the trial. But simple things like cranberry, D-mannose, they
Hmm.
would be fine.
Okay, that makes sense. And is it possible to participate in the trial in a language other than English?
Yeah, so we have a lot of the trial sort of documents. They're available, I think, currently in 3 languages
Hmm.
with plans for more. So yeah, we want to be as inclusive as we can, and we specifically want, some to target certain ethnic groups because they're just very, very underrepresented in clinical trials in this topic
Hmm.
area. So absolutely.
Yeah, that sounds great. It'd be great to have a focus on that. And when do you expect the outcomes of the trial to be available?
So if we start recruiting in February of this year, we'll
Hmm.
recruit for 20 months. We'll observe patients for a further 1 year. So, realistically, it's going to be 4 or 5 years before these results have a significant impact. But what we've shown with our previous work is if the results are good. So, of course, in Newcastle, we did the methenamine trial,
Hmm.
and within a period of months, it had changed the European guideline, and only just has changed the NICE guidelines. So, these guideline writers are kind of that these kind of research projects are on their radar.
Right.
So what used to be a very difficult step to change a guideline or a policy is proving to be a little bit easier in the kind of modern world.
Well, that's
So
good to
I'm
hear.
hopeful that it will have an impact pretty much as soon as the results come out. And that's one of the advantages of doing a very pragmatic clinical trial, so that, it can be generalizable, it can be, the results can be extrapolated, and also can be used to formulate guidelines and change policies.
Which is the ultimate goal, right? We need to
Indeed.
change outcomes for patients. So we're really looking forward to seeing the results. And maybe we can have another chat as you go through the trial. You can share some updates with the community.
Yeah, absolutely. I think it'd be particularly good to inform with regards to recruitment and whether there's been any kind of, well, I hesitate to call them teething problems, but there's always issues on any clinical
Yeah,
trial, and
for
if we
sure.
get any early signals, I'd be happy to share them.
Oh, that sounds great. Well, thanks again so much for joining me so that we can answer the community's questions. And I look forward to keeping everyone updated as the trial progresses.
Thank you. Thank you very much.
Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.